pharmacologic interventions for behavioral disturbances of dementia. I want to start with a story. I had a situation just on Monday that's very relevant to this topic. So I'll call my residents alphabet letters. We had K and L. So resident K has frontotemporal type dementia, and he's been at our memory facility for about a month. And he was previously at another memory facility where he was medicated heavily. He was on quetiapine 25 3 times a day. He was on lorazepam 1 milligrams 3 times a day scheduled, in addition to an SSRI. And even with those medications, he was beyond the ability to care for him at that facility. So that facility discharged him due to inability to meet his needs. And he was at home for a time with family. And while he was at home, family weaned him off some of those medications and kept him on some of his other routines. And then he came to our facility about a month ago. And we had discussion with the family about kind of pros and cons of medications, and he's new to us, and let's observe how he does. We knew from the get-go that he was very active. When I listened to Kay's lungs, I said, you would have thought I said ready, set, go instead of take a deep breath, because he just started running across the unit. So we knew kind of from the get-go that this was a very active resident. And on this past Monday, I called to check on somebody totally different. And the nurse said, I'm glad you're calling. This is what's going on with Kay. Kay has attacked resident L. He had, I believe, a piece of he had something that he was able to get and use as a weapon, an arm of a chair or something of that nature, that he was using to actually attack and hit another resident. So he hit resident L, and thankfully resident L was not significantly injured, but we did send resident L to the hospital for attention. They attended to him and sent him right back. And resident K had some one-on-one attention. Unfortunately, later in the day, there was another incident where resident K was hitting in the face another resident, and in short, the situation escalated to needing to get the police involved for safety. And I guess I'm getting ahead of myself. Earlier in the day, I spoke to the family of resident K after the first incident and before the second incident, and discussed medications and discussed psychiatric inpatient care. And I basically presented to the family 3 options that we were considering, one being, let's keep him at our facility and adjust medications from our standpoint, and I recognize he had been on medications previously that the family had felt like was excessive, and let's maybe look at something different and start very low and titrate up. And a second option I discussed with family was a transfer to an inpatient psychiatric facility. And the family instantly was very worried that that resident K would not be able to come back. That was the very first question that the family asked. Like, well, if resident K leaves, will he be able to come back? What's going to happen? And so, I assured that the plan would be to get kind of medication adjustment, stabilization set up outside, and then get him back. And, the third thing I presented was that if there is a safety issue, that it would be an emergency transfer, and that would be the last resort and not my preference, but of course, depending on safety concerns. So unfortunately, later in the day, that's exactly what happened. There was a lot of concerns for both the staff and other residents' safety with how resident K was behaving. He was banging on windows to the nurses' station, trying to get at staff that were locked inside of the nurses' station, and as I say, kind of had altercations with 2 other residents on the unit, one of which went to the hospital for care. So this was really a significant event or day. This was one event was like 5 a.m. and the next was after lunch. And so this was a very significant episode, which kind of highlights the challenges of what I want to talk about today with regards to, when behaviors might get to a point where there's safety concerns and what's our plan, both from the medication side and the non-medication side. So with that, I'll jump into the topic and the other reason that this is a hot topic, so to speak, is because it's in the news. So this is from September 11th. There was an article in the New York Times. The headline is "Phony Diagnoses Hide Rates of Drugging at Nursing Homes." So, if you're not in the nursing home field, you instantly are, oh my gosh, this is horrendous. And you really are. And of course, that's the one of the points of news, right? To catch your attention. And I did read the article, and I put the link there for those who might be interested in reading it. But in short, it discusses the use of diagnoses like schizophrenia for individuals who have behavioral disturbances from dementia. And from a medical standpoint, we know that that's not accurate. People do not develop schizophrenia in their 80s. It's not a new diagnosis that occurs when they arrive at a nursing home. If they have a diagnosis of schizophrenia, that is something that they have been given prior to them coming to us. But unfortunately, what has happened is that diagnosis has been given to residents who need antipsychotic medications that were originally studied and designed for individuals with schizophrenia, with those types of diagnoses. And I agree 100% that that's inappropriate. The labeling somebody with a diagnosis that is not a true accurate diagnosis in order to justify a drug treatment is not okay. But of course, there's more to it than meets the eye. There's definitely, as I illustrated with a story just from 2 days ago, there's significant behavioral disturbances that can occur with dementia that can provide or can result in safety concerns for other residents and staff. So next slide. So we're in this balance of trying to utilize medications for their therapeutic benefits and manage moods, behaviors, etc. And then the pressure to reduce the use of these medications. Next slide. So these are kind of all the thoughts that came to my mind as I was trying to think of making this balance. Safety, number one. So safety can come from two lenses, right? We can look at the safety of that community, of all the residents on that unit that could be a potential harm based on physically aggressive behaviors. But of course, there's the safety of the individual. If we're medicating inappropriately, that individual is at a risk of falls, of oversedation, of side effects. So, it's definitely a balance. What are the goals of care of the patient, and what care coordination can we do with multiple team members? How are we documenting it? How are we doing the non-pharmacological interventions? How are we consenting and documenting that the medical power of attorney or proxy decision maker is aware of the situation, and that we've had discussions there. And we'll talk about gradual dose reduction with regards to these psychiatric medications. So we'll review some regulatory guidelines and then describe kind of circumstances where medications could be considered, and then some of the challenges with medications. So this is the F757 with regards to unnecessary drugs. So basically, our goal is for each resident's drug regimen to be free of unnecessary medications. And an unnecessary medication is defined as something that's excessive amount, or perhaps two medications in the same drug class Perhaps it's on for an excessive amount of time. It should have been discontinued previously, and that didn't happen. And perhaps it's something that has not had the appropriate indication, as we mentioned, with regards to diagnoses that match the medications. And then if there are adverse, the first thing in prescribing medications is first do no harm, right? So if there are adverse consequences, then that should be a flag for evaluating if that's a necessary, or if that's an unnecessary drug for that individual. And with regards to psychotropic drugs specifically, this is just the definition. So any drug that affects the brain is considered a psychotropic drug. So including, but not limited to, antipsychotics, antidepressants, anti-anxiety medications, and hypnotics. And this is just going further into the psychotropic drugs. And as we assess residents in our facilities, we need to ensure that these drugs are only given when there's a necessary situation for them, a necessary treatment plan. There's a specific condition that's diagnosed and has been documented in the record. And we know these psychotropic drugs are on a schedule to be evaluated for dose reductions, and then using non-medication interventions as appropriate. The PRN orders are also very much intended to be limited. So psychotropic drugs that are ordered as PRNs are meant to be limited to 14 days unless there's additional documentation of the necessity of extending that beyond 14 days. And this is a slide that I took from a pharmacist lecture about dementia, and the drugs we're talking about are all medications that in an ideal world should be avoided in dementia. So with regards to antipsychotics, they can increase the risk of stroke and mortality in those with dementia. Benzodiazepines are sedatives, and those can have an increase in fall risk or sedation or other issues. Hypnotic drugs, which would include Ambien, which is zolpidem, have known effects on the CNS system and can have side effects of a concern. And then long-term opioid use can also have effects on cognition. So, these are medications that are recommended to avoid in dementia. Obviously there's situations when we use them. So we'll try to, again, talk about that balance of how we can be thoughtful about using things in an appropriate way. So there are currently no FDA-approved pharmacologic treatments for the management of psychosis in dementia or behavioral disturbances of dementia. So if we are using a drug for that purpose, it's really essential that we continue to do non-pharmacologic options or interventions, and that we're evaluating that we have set goals. Is the medication helping us with that goal, and that treating what we want it to be treating? And if not, let's change it, let's stop it, let's reduce it, what have you. So before beginning a prescription intervention for behavioral management, mood management, these are some questions to ask. Is this drug therapy appropriate for the symptom we're trying to address? Does the symptom usually respond to medication management? And what drug category might be most effective in treating that symptom? What are the side effects, and what would be an appropriate timeline? I'll expand that to say not just duration of therapy, but what would be an appropriate timeline for some ongoing monitoring, where we're looking at maybe we need to look at an increase and then later at a decrease and a discontinuation. So what will be our monitoring plan? And pharmacologic therapy should always be in addition to and not instead of the good behavioral interventions, environmental interventions that we've been talking about for the last couple of weeks. Non-pharmacologic strategies, when non-pharmacologic strategies have been tried and not been effective, and there's either caregiver burnout or safety concerns, that's when we might consider medication prescriptions. And really that comment about caregiver burnout, I would think that that's really more, or I would indicate that that's really more appropriate in that outpatient setting. So in my office practice, I might consider those medications to help keep that person at home and not being transferred to a community a facility type setting. And of course, there's burnout in our setting as well. But when you have a caregiver that's a 24/7 caregiver and is a family member, that might look a little different than our staff dealing with these behaviors. And we also know that individuals with dementia respond very differently to persons in their family versus unrelated caregivers. So in a facility setting, of course, we've got to document very specifically what the behavior is, the symptom is, and what the goal of therapy is. And if that behavior is presenting a danger, we are going to document that and have justification for intervening. And a comment about, some of the psychosis symptoms related to dementia. It's really only if those are becoming unsafe to the individual or those around them. So the fact that a patient is hallucinating does not mean we need to take that away with medication. So, if they're hallucinating that somebody's coming at their face with a knife, that might be kind of scary. That might be a reason to discuss a medication and intervention. But if it's not causing them any distress, then we do not need to medicate that. And so once medications has been selected, the geriatrics mantra is start low and go slow with medication dosing. And every patient is different. There are, little 90-year-old ladies that weigh 80 pounds that are going to be different than, maybe a younger 200-pound man that's has a little bit more strength. So, and needs a little bit higher dose of medication. So everybody's going to be different on adjusting medications and assessing symptoms in response to treatment. So one thing I want to advocate for is if we're starting something new, we need to look at stopping something when we talk about the medications that are on the list for behavioral and mood management. And I've been trying to do a better job of that just from my perspective. If they're on a mood stabilizer and we're looking at an antipsychotic, let's get them off the mood stabilizer and try the antipsychotic instead, or vice versa, as opposed to just adding on, different medications. And the ultimate goal is quality of life. So again, kind of evaluating, are we getting what we want? And if not, let's reassess and change. And so the question of how long, that's a little bit of a tough one. Again, kind of there should be a schedule for reassessing and getting input from the caregivers, the CNAs, the nurses, and the family. And there's not a specific recommendation for these medications in the setting of behavioral disturbances from dementia, but we have observed that as patients go through phases or different stages of dementia, aggression may calm and they may not need medications. So definitely regular assessment is important, because otherwise, medications might get started and they're needed, and we forget about them, and now they're not needed, but we've forgotten to evaluate for stopping them. So our pharmacy colleagues help us definitely with that, with regards to providing regularly scheduled medicine reviews and recommendations on gradual dose reductions. So we'll talk about that, I think, a little bit next. And so kind of the key points on my section, and we'll be transitioning to RT for some information about the critical pathways and how we can apply some of these principles in practice. But the psychotropic medications are only when necessary. We need to document the diagnosis, the anticipated benefits, the anticipated length of use, and we need to evaluate for a gradual dose reduction or for other non-pharmacologic interventions. So again, our pharmacy colleagues help us with that. So those, messages about gradual dose reductions can help provide some structure for formally reassessing what is really needed and being thoughtful about how we respond to those. And again, the medications PRN, the psychotropic the antipsychotic medications specifically are not meant to be used PRN. And one situation that may be common, may not be as common, is getting those medications started by hospitals. So really, I discontinue those on admission if they've ordered as needed antipsychotic medication in the hospital setting. There are other psychotropic medications as needed that we may have on board. And again, that recommendation is to limit to 14 days and document if it's needed longer than that. So I think that's all I've got. I'll pass to Arti for kind of continuing this discussion. We'll get her slides up here shortly.
Thank you, Dr. Ross. So today we are going to focus on the QI portion on medication management of dementia. And we are going to look through the critical element pathway and see like what are the things that you need to observe, how to keep your facility survey ready, and look at an F758 tag and go on from there. Next slide, please. Okay, this is what is our learning objective for the QI portion today. We are going to review the critical element pathway, and we are going to look at one example. That's the F758 tag, and we will review all of those. Next slide. Okay, so this is the critical element pathway. It is the form CMS 20082, and it is for unnecessary medications, psychotropic medications, and medication regimen review critical element pathway. This is a great way to keep your facility survey ready. So this is something that the surveyors use to evaluate. So you're doing this, you should be doing this on a regular basis to make sure that you're not giving any unnecessary medications, and especially focusing on the psychotropic medications, the use of it, and the PRN use not extending beyond 14 days. As in all the critical element pathways, there is an observation piece, and then it goes into what are the interviews to be done for residents, staff, pharmacists, and that's how the surveyor kind of evaluates if the facility has all the protocols in place. And if they see something is missing, then that's when they tag you on F757 or F758. Next slide, please. Okay, so these are the observations that the surveyor is going to make. So this is a great way for you to assess your facilities, plans, and protocols regarding these unnecessary medications that could be used for a prolonged time or for a longer duration, or not being followed on the gradual dose reduction protocol. So a few of these questions are like what non-pharmacological approaches to the care were used. As Dr. Ross mentioned, the pharmacological intervention is an adjunct to the non-pharmacological approaches. So always make sure that you're documenting all that non-pharmacological approaches that were done and were they effective or not, and then document what were the pharmacological interventions that were used, what was the medication that was used, and was it effective or not. How does the staff respond and interact with the residents, and does the resident continue to show expressions or indications of distress, and other things like what are the adverse consequences that could be related to medication. So that's this list on the right side, which are some of the adverse consequences of the medication. So it's important to look into all this and document them and have them on the medication chart for the resident. Next slide, please. Okay, this is the how a surveyor would do the observations and then would start interviewing residents, family, or resident representatives. So these are a couple of questions that the surveyor would ask them about what medications do they get and why do you need to take them? Like, does the resident or the family member or resident representative know what are the medications that are being prescribed? Why are they taking them? What are the goals for those medications, and were they informed on the risk, the benefits, and potential side effects of the medications? And if there were any changes in the medications, was gradual dose reduction for those psychotropic medications followed or not? What alternatives were given for them before starting these pharmacological approaches? And do they think that the medication has helped them, like either with decrease in their mood, has helped them with the pain control, or has it helped with improvements in function? And of course, knowing like what are the side effects that they have experienced, and have they participated in any of the discussions or care plan meetings about their medications. So it's important you involve the resident, their family, in any of those care plan meetings that you're going to do, even if it is for starting a new medication or changing the medication or planning on a gradual dose reduction for those medications. Next slide, please. Okay. So the next set is about staff interviews. So the surveyor would definitely use this too to interview the staff to see like whom do they report the changes in the resident status if anything happens, if there is distress or pain, or if there's any adverse side effects, where do they report, how do they report, and what are the things that they do to make sure that the resident is safe or there's no hazard due to the medication. And what do they know about the resident's daily care needs? Again, very important, like what non-pharmacological approaches were used, what is the clinical indication for the medication, what is the facility doing to monitor those medications. So again, they have like a subset of questions there about what are the things that they do to monitor those medications and how do they assess whether each medication is effective, and a couple of other questions. So these are for staff interviews. And again, this is a great tool for you, for your facility to review it with your staff to know that they know the processes and then everything is being documented and monitored well. Next slide, please. This is pharmacist interview. So the surveyor would interview the residents and the families. They would review the, interview the staff, and then they would interview the pharmacist too. So the pharmacist interview consists like what do they, how like do they perform a monthly MRR, which is like medication review, and do they include each resident's medical record in their monthly review? How do they evaluate this PRN medications, especially if it is related to psychotropic drugs and antipsychotic medications? What are they reviewing, like the dose, what is the continued need to extend it, and adverse consequences? And it's always important that they report it to the attending physician, the medical director, and the DON if there's any irregularities with the resident's medication regimen. So again, documentation is an important thing, and communicating it with the care plan team is more important. And there are a couple of other questions for short stay residents, long stay residents. What does the interdisciplinary team do to review this resident's medication and things like that? Next slide. Okay. And that same critical element pathway, that form, has this last segment, which is the medical record review, also known as MRR. And that has a couple of questions about what was the underlying cause of the condition or symptoms requiring the medication that was identified. And if the medication was discontinued, was there evidence of the gradual dose reduction? And did the pharmacist conduct a MRR for the resident at least once a month? So it's important that you're doing this with the pharmacist every month. Again, if the pharmacist informed any medication irregularities to the attending physician, to the medical director and DON, was it documented on a separate written report? And what was the actions that was taken to address it? Again, if the attending physician documented it, and what was the action taken, and things like that. Again, there is this CMS adverse drug event trigger tool. It's a great tool to record any of those allergic reactions and monitoring plans. So these are the questions for medical record review, and it's important you do this on a regular basis to ensure that you're documenting all of those efforts. And this is one example, which is F758, and it is like immediate jeopardy example. Just let's go through why was this facility tagged for it. So the facility failed to meet professional nursing standards of practice for one of their residents, and he or she was administered an excessive dose of an antipsychotic. So what happened after that? The facility allowed an unauthorized psychiatric consultation that resulted in an unnecessary antipsychotic medication administered in an excessive dose, and there was no in the absence of any documented behaviors or symptoms. So it was not a need for starting that medication. And they didn't involve the attending physician or the interdisciplinary team or even the family. So they were just started on that medication without any indication for starting that medication. So what did this result in? The resident suffered from adverse consequences because of that significant medication error and unnecessary antipsychotic medication, and the resident became lethargic and exhibited symptoms from an adverse drug event. So this was the reason for their being cited. Next slide. So immediate jeopardy began because the resident psychiatrist ordered the resident an antipsychotic medication based on incorrect information that the resident was delusional, thinking he was marrying a staff person. So it was just based on that phone call that they assumed resident was delusional. He was thinking he was marrying a staff, and the resident psychiatrist just started off on an antipsychotic medication. But the actual harm occurred when there was no monitoring of the resident for adverse effects from the drug. And that resulted in decrease in nutritional intake with weight loss, reduction in physical abilities, increased sleepiness and lethargy, and a slow decline in quality of life, as evidenced by his decreased participation in activities of his choice. So this is something which was immediate jeopardy. There were like lots of things that were going on with this facility and the resident. Multiple things went wrong, and that's why it is an IJ tag. And of course, the facility had to work on a plan of correction for it and make sure that they're documenting, doing the medical record reviews properly. So what are the key points that we need to have in mind is first, definitely do a routine review of those high-risk medications, have an acceptable clinical indication for you. So whenever you're documenting, make sure that you write down your clinical indication and have like written protocols or resources to guide high-risk medication use, when it should be used, when it should be stopped, how it should be stopped, and things like that. Establish a monitoring system for each of those medications, which includes like what is the dosing, what is the duration for those medications, what is the clinical rationale if you're wanting to extend the use of medication, how are you going to monitor for any of those potential adverse consequences. And then, of course, when you're doing a gradual dose reduction for the psychotropic drugs system, have a system for it and document it. And adherence to this PRN requirements is important. Make sure if you're extending beyond those 14 days for the psychotropic and antipsychotic medications, you have a clear indication documented. And medication care plan with these individualized approaches should include what is the medication as well as non-pharmacological interventions that were tried. Next slide, please. Okay, these are the references. This gives you the FTAG series, like what are the ways that a surveyor could look at the critical ailment pathway and observe and tag you on those things that we spoke about, F757 or 758, and there are a couple of other tags too. Medication safety nursing homes change package from TMF is a great tool. I would definitely say that you would need this, download it and use each of those elements. And this critical ailment pathway, if you want to look through what it has, what are the components of it, and do a mock drill with your facility, then this is